Hello there, Dr. Vincent Lau here, coming at you from the University of Alberta Critical Care Program and the albertasono.ca website. Today's lecture will be on transcranial Doppler and its uses in the critically ill patient. Just as a disclaimer, I have no professional or financial disclosures to note. However, it is important to realize that POCUS TCD is primarily used as a rule-in for neuropathology in the neurocritically ill patient. Today we'll be focusing on the transtemporal window, although the transforaminal as well as the transorbital windows are part of formal TCD. We will also be focusing primarily on the middle cerebral artery today, but just note that the ACA, PCA, vertebral artery, and basilar arteries are part of formal TCD rule-outs. Today's podcast will primarily focus on the basics of neurosonology, which includes vasospasm assessment, raised ICP, and cerebral circulatory arrest. For more in-depth coverage, we suggest checking out the articles seen here, which includes the point-of-care transcranial Doppler by intensivists, which will go over the background, calculations, and methodology of this modality, as well as a how-to in the Better with Ultrasound series in chest. Just as a quick piece of background, when we speak about TCD, the traditional TCD is seen on the left here, with a non-imaging probe placed in the transtemporal window that primarily only produces spectral Doppler. Our TCD is actually TCCD, which stands for transcranial color-coded duplex sonography, which includes the color box for imaging, as seen on the right here, as well as spectral Doppler with the pulse wave interrogating here and producing the spectral Doppler signal seen here. As mentioned previously, point-of-care TCD has uses including post-subarachnoid hemorrhage vasospasm interrogation, raised ICP, as well as cerebral circulatory arrest interrogation for brain death, as well as midline shift assessment. Additional formal TCD indications include stenosis, emboli, which includes microemboli and strokes, shunt interrogation, paradoxical emboli, right to left shunts, as well as AVMs, sickle cell hyperemia, cerebral motor vasoactivity, as well as syncopal and positional vertigo assessment. This is beyond the scope of this particular lecture, and the indications below should be interrogated by formal TCD. Further reading can be found at the AIUM. Just as a background primer on anatomy, we can see here a typical circle of Willis, which is not always seen in every single patient. We can see here that the bilateral internal carotid arteries give rise in continuation to the middle cerebral arteries, which are actually technically not part of the circle of Willis. The remaining part of the circle includes the anterior cerebral arteries, seen bilaterally here, with continuations and an ACOM in between. We also have the posterior cerebral arteries, seen here, that are given rise from the basilar arteries, which are given rise from the vertebral arteries bilaterally, which are from the bilateral subclavian arteries. The PCOM arteries are seen here, which make up the rest of the entire circle of Willis. However, when we do PCD, we rotate that image on its axis 90 degrees, and this is the typical orientation that we would see. So again, we have the ACAs seen bilaterally here, with the anterior communicating artery seen here, ICAs with continuation into the MCAs, PCOM arteries, which are attached to the PCAs bilaterally here. This is all usually anterior to the bilateral cerebral peduncles or the bilateral thalami, which look like a heart-shaped or butterfly image on 2D ultrasound. In terms of TCD scanning and technique, we use the pulse wave spectral Doppler velocity to interrogate the MCA from the transtemporal window. On our POCUS machines, we used our phased array probe, which is 2 to 5 megahertz, and we place this on the transtemporal window on the transtemporal bone. If we have a TCD preset on our machine, the index mark will be faced towards the frontal bone or the patient's eyes. If your machine does not have a TCD preset, you can use the cardiac preset. Just know that the index mark will need to be pointed towards the patient's occiput or the back of their head. As you can see here with our TCD preset, we can aim the index mark towards the patient's eyes or their frontal bone in the transtemporal window. The transtemporal window can be broken down into many different areas, including the frontal, anterior, medial, and posterior areas. Different angulation and inclination might be required to interrogate the MCA in plane. Alright, so let's get to a case. There's a lady in her 60s, with a worse headache and life presentation, and a decreased level of consciousness with a GCS of 10/15. Her plain CT shows this subarachnoid hemorrhage with interparenchymal hemorrhage as well, and a ventral CTA shows a P-column aneurysm that is ruptured. She's then GDC coiled by neurosurgery and is eventually transferred to the neuro-obs unit in stable condition. However, on post-admission day 3, she has repeat decreased level of consciousness, this time deteriorating to 5/15 GCS, with a CT head that is unchanged, no evidence of rebleed. So the question is whether or not she has vasospasm. So let's start scanning. As we can see here, we're shooting through the transtemporal window where we see the ipsilateral temporal bone seen here, and the contralateral temporal bone seen usually at a depth of 13 to 16 centimeters, depending on the patient. We also see here the bilateral cerebral peduncles, or bilateral thalami, which look like a heart or butterfly shaped. We can see here that the color box has been turned on, and it's been placed immediately anterior to the cerebral peduncles or thalami, and we're looking primarily for the circle of Willis. As we play the clip here, we can see the bright color of the MCA, which comes out towards the ipsilateral temporal bone. It should be red in color as it's going towards the probe, as seen by our Nyquist here. Keep in mind that if there is low flow states within the cerebral vasculature, we may have to turn our Nyquist down in order to see cerebral blood flow. Now we'll use pulse wave spectral Doppler and the equal sign over the MCA, which is usually at a gate depth of 3.5 to 5.5 centimeters. A typical spectral Doppler or normal MCA blood flow is seen here. As you can see, there's a normal systolic upstroke with a decelerated diastolic phase. It's important to note when tracing out your area under the curve, or otherwise known as the velocity time integral, that you need to go at the beginning of systole all the way up to the peak systolic velocity and ending at the end of diastole at the end diastolic velocity. Remember to click here, and then immediately a line would be drawn down to the baseline. Do not draw down to the baseline yourself during the trace, as your end diastolic velocity will be set to 0 and not at the proper end diastolic velocity. As you can see here, there's a whole bunch of numbers that pop up on our machine that are pre-measured or pre-calculated. The TAV, otherwise known as the timed average velocity, represents our mean velocity. Peak systolic velocity is the highest velocity during the entire cardiac phase. The end diastolic velocity is seen here and represents how fast things are going at the end of diastole. You'll notice, as mentioned before, our gate depth is somewhere between 3.5 to 5.5 centimeters for the proper insonation of the MCA. You'll notice also the PI here, which stands for the pulsatility index, which is an index of the peak systolic velocity minus the end diastolic velocity over top of the mean velocity. We'll talk more about the pulsatility index when we talk about cerebral circulatory arrest and raised ICP. The mean velocity here is also used very importantly to assess for vasospasm. So as mentioned before, the mean velocities are used for vasospasm interpretations. A normal mean velocity of the MCA is somewhere between 50 and 80 centimeters per second, or usually less than 80 centimeters per second. Vasospasm, in turn, has several different cutoffs in terms of its severity. Mild vasospasm starts at about 120 centimeters per second to about 160 centimeters per second. Moderate severity goes from 160 to 200 centimeters per second, and anything above 200 centimeters per second is considered severe vasospasm. As we can see here, the trace of the VTI is much higher in this patient with severe vasospasm. As we can see, the mean velocity is definitely over 200 centimeters per second at 229. This is an example of severe vasospasm, and we can see both the systolic upstroke as well as diastole are both increased because of vasospasm. So vasospasm can be diagnosed with absolute values in MCA velocities, but what would happen if there was a high output state or a low output state that would influence these values. For example, if the patient has concomitant circulatory failure requiring high dose vasopressors or inotropes, would that theoretically decrease the amount of cerebral blood flow? Opposite to this, if the patient had a high output state, such as hyperemia from high cardiac output, would that falsely elevate the MCA velocities? This is where the Lindegaard ratio is quite important to help diagnose vasospasm. The Lindegaard ratio is the mean velocity of the MCA indexed or divided by the mean velocity in the ipsilateral extracranial internal carotid artery. Basically, we're trying to figure out whether or not the mean velocities in the intracranial vessels are vasospastic compared to vessels that are outside the cranium. Therefore, we can determine whether or not high MCA velocities are truly secondary to vasospasm or they're secondary to hyperemic states. The Lindegaard ratio is the MCA over the ICA mean velocities, where less than 3 is usually secondary to hyperemia, greater than 3 to 6 is about mild to moderate vasospasm, and greater than 6 for a Lindegaard ratio is severe vasospasm. Basically here, we're using the phased array probe to do an interrogation of the ipsilateral extracranial internal carotid artery. This is the common carotid artery. This is the extracranial external carotid artery. And the continuation of the CCA leads to the ipsilateral extracranial internal carotid artery. You'll notice that the flow will be blue in color, as seen by our Nyquist here, as the flow is moving away from the probe. And as you can see here, will be noted below the baseline. We take the mean velocity from here, or the TAV, and use that in our Lindegaard ratio index. As measured previously, the ratio of the MCA as well as the ICA leads to a ratio of 6.2, and as we know, based on the Lindegaard ratio of greater than 6, that indicates severe vasospasm. So this is a nice confirmatory way to assure that both the mean velocity on its own as well as the Lindegaard ratio support the diagnosis of severe vasospasm. Let's have a look at our second case, which is a 50-year-old male who's involved in an MVC multi-trauma, but it was at very low speeds of only 10 kilometers per hour. He was noted to suffer a TBI and had a VSA arrest at the scene. His subarachnoid hemorrhage was either secondary traumatic from the TBI itself or a ruptured aneurysm, which was confirmed later on CTA. So our 50-year-old gentleman with presumed ruptured aneurysm leading to subarachnoid hemorrhage and anoxic brain injury, where the neurocritical care team determined that he had a poor prognosis. Eventually, the patient had Cushing's response with hypertension, bradycardia, and also irregular respirations, in keeping with the possible herniation syndrome. The patient became very hemodynamically unstable and required vasopressors of norepinephrine and vasopressin to maintain his blood pressure. A bedside POCUS TCD was asked for in regards to cerebral circulatory arrest or brain death. So raised ICP as well as cerebral circulatory arrest has a stepwise pattern noted here in the Hassler diagram. You'll notice here that as ICP increases and therefore CPP or cerebral perfusion pressure decreasing, you'll eventually lead to cerebral circulatory arrest. You'll note here at the beginning that the patient has a normal systolic upstroke and a normal deceleration of the diastolic phase. As time goes along, as the vessels in the brain have external pressure come from ICP, you'll notice that the systolic phase rises a bit. And you'll notice that during diastole, because it's a relaxation phase, ICP can sometimes become more than the diastolic phase, and you eventually get what is known as diastolic blunting. Diastolic blunting can even occur when ICP is greater than diastolic pressure, to where you actually have flow reversal during the diastolic phase. You'll notice that the area under the systolic curve and the area that is flow reversed in the diastolic phase is equal to each other. The way to think about it is that a red blood cell, which is going equally forward as well as equally backward, is no longer going back to the lungs to get further oxygen onto its hemoglobin, and eventually that will lead to anoxic brain injury. So that is one of the first stages that you will see in cerebral circulatory arrest, which is known as biphasic flow or oscillating flow, where the red cells are just going equally forward and equally backward. The next phase of cerebral circulatory arrest is whereby systole is also affected, whereby the pressure is now affecting systole. This is also known as small systolic spike waves. You'll notice that they don't come above 50 centimeters per second and don't last more than 200 milliseconds. This is important because when we put 50 centimeters per second into a modified Bernoulli's equation of 4v squared, the 50 centimeters becomes 0.5 meters per second. We square that and get 0.25 and multiply that by 4. The modified Bernoulli's equation of 4v squared changes a velocity into a pressure, and this pressure is equal to 1 millimeter of mercury. So therefore, small systolic spike waves of less than 50 centimeters per second and lasting less than 200 milliseconds only produce a perfusion pressure of 1 millimeter of mercury, which is not conducive with life. The last thing you'll note is that eventually all flow will cease inside the cerebral circulation. This is harder to diagnose than oscillating or biphasic waves and systolic spike waves, because you have to prove that there was previously cerebral blood flow, and it's not just a technical issue with measurement. Therefore, usually what ends up happening is we have to prove 30 minutes prior that there was some cerebral blood flow, and then 30 minutes later showing no intracranial blood flow whatsoever. This requires more interrogation, where we can't just insonate the MCA, but we also have to look for evidence of lack of flow in the ACAs, PCAs, ACOMs, PCOMs, as well as the vertebral and basilar arteries. This is usually the realm of formal TCD. We need to insonate all the cerebral head vessels to make sure that there's no flow in any of them. And subsequent to this, we also have to prove extracranial blood flow by looking at the carotid arteries to see whether or not there's blood flow there. This is the hardest form of diagnosing cerebral circulatory arrest. So here we've put a color box over where the MCA should be. And what we see here are flashes of flow, not continuously throughout the systolic or diastolic phases. This is indicative of cerebral circulatory arrest. Typically, we would see red blood flow going towards the probe, as indicated by our Nyquist here, in both the systolic and diastolic phases. But that is not what is seen here. When we insonate the MCA, we see that we are in the phase of diastolic blunting, whereby systole is still present, but diastole is completely blunted. When we scan the patient 5 minutes later, we notice progression, whereby systolic spike flows were present and also diastolic flow reversal was also present. This patient was progressing to cerebral circulatory arrest or brain death. This was later confirmed on apnea testing as well as brainstem reflex testing. In conclusion, transcranial Doppler TCD POCUS is a non-invasive, quick, easily repeatable, and performed at the bedside tool for a multitude of neuro-ICU applications, which includes vasospasm, raised ICP, and cerebral circulatory arrest and midline shift. The previous impedance to use of TCD was secondary to lack of machines and expertise. However, with the ubiquity of point-of-care ultrasound machines, hopefully TCD POCUS can become more widespread. Thanks for watching this primer on TCD POCUS. If you'd like to learn more, please read our Critical Ultrasound Journal as well as our Chest Journal articles, which will delve deeper into the subject. Thanks for watching and have a good day.